You had a PRP injection, it helped for a few months. Then the pain came back. And nobody explained why. Today, I'm going to explain exactly why PRP injections fail. Not always, not in every patient, but specifically why they fail in moderate to advanced knee arthritis. I am Dr. A.K. Venkachalam, FRCS, UK trained orthopedic surgeon. 4 decades in this specialty. I stopped recommending PRP as a standalone treatment for a very specific biological reason. That reason is what this video is about. What PRP actually does. First, let me be fair to PRP. It is a real biologic. It is not a gimmick. Leukocyte-poor PRP, prepared correctly, does reduce inflammation inside the joint. The published literature confirms this. A 2025 narrative review of 40 high-quality studies showed that LP-PRP outperforms steroids and hyaluronic acid for pain and function in mild to moderate arthritis. Kellgren-Lawrence grades 1, 2 and early grade 3. In those patients, PRP is genuinely useful. I use it myself. It is layer 1 of the PRASAD 3-layer orthobiologic treatment. So what is the problem? The knee is not a single biological structure. It is 3 separate tissue layers, each with its own disease process, each requiring a different treatment. Layer 1, the synovium. This is the joint lining membrane. This is where inflammation lives. This is where PRP works. Layer 2, the cartilage. This is where structural damage is happening. Collagen fibers start breaking down. The sponge turning to glass. Layer 3, the subchondral bone. This is where the deepest, most disabling pain originates. Bone marrow lesions, internal fractures, intraosseous pressure crushing the nerve endings inside the bone. A single PRP injection, even an excellent one, reaches layer 1. Layer 2 receives no cellular workforce. Layer 3 receives nothing at all. You have treated the smoke alarm, not the fire. And you have not even touched the cracked foundation. The published evidence on PRP monotherapy is consistent. Across multiple meta-analyses, PRP delivers a 2 to 3 point reduction on the pain scale and 10 to 20 points on the WOMAC functional index over 6 to 12 months. Meaningful? Yes. Sufficient for moderate to advanced disease? No. In 2025, the Gobbi Foundation in Milan published the PRASAD trial, platelets, adipose, stromal treatment for arthritis. 131 patients, 4-year follow-up. This trial combined PRP with MSCs derived from stromal vascular fraction, a 2-layer approach. At 6 months, the KOOS Quality of Life subscale improved by 43 points. VAS pain reduced by 57%. At 4 years, pain reduction remained at 65%. That is, 65% of the patients were pain-free at 4 years. Sustained, without surgery. That is not a stronger PRP. That is a different biological category. That is PRP and MSCs. Second, the metabolic problem. There is a second reason PRP fails. One that the clinic that gave you the injection almost certainly did not discuss. PRP is a growth signal. It tells your tissue, repair. But if your metabolic environment is hostile, if insulin resistance is elevated, if HbA1c is creeping above 5.7, if systemic inflammation is chronically raised, that is your HSCRP, then you are trying to grow a garden in a poisoned soil. The growth factors from PRP cannot overcome a joint being continuously flooded with inflammatory signals from adipokines, from glycated collagen, from uncontrolled insulin resistance. This is why the same PRP injection produces excellent results in one patient and no results in the next. The injection did not fail. The metabolic foundation was never prepared. PRASAD, the three-layer solution. This is why I developed the PRASAD orthobiologic treatment. PRASAD addresses all three layers in a single sitting. Layer 1, Leukocyte-poor PRP combined with Kavach, our A2M application, which traps and neutralizes the destructive enzymes before regenerative cells are deployed. Layer 2, SVF, stromal vascular fraction, harvested from the patient's own fat, a paracrine signaling cell population that modulates the cartilage microenvironment. Layer 3, BMAC, bone marrow aspirate concentrate, delivered directly into the subchondral bone via intraosseous injection. This is not a stronger PRP, this is a fundamentally different biological architecture. The full PRASAD orthobiologic treatment is covered in detail in a dedicated video published on April 12th. Check it out. That video covers the metabolic triage, the 4-marker pre-treatment panel, the techniques, and the eligibility criteria. Watch that video before making any decision. If you had PRP and it didn't hold, your biology was not broken. You received a partial treatment for a 3-layer problem. The question is not whether PRP works. The question is whether one layer of treatment is sufficient for your stage of disease. For most of my patients, particularly grade 3 and grade 4, the answer is no. Joint preservation is not about one injection. It is about a biological system. If you are considering treatment, details are in the description below. I will see you in the next video. In the next video, I will explain why cutting of the wires will not stop the signal. Subscribe and wait for that video.